All right, Sleemers, I back again with another case of chest pain. So imagine a patient arrives with a chief complaint of chest pain and shortness of breath after a coughing spell the day before. Her initial vital signs are she's a little bit hypertensive at 158 over 97. She's not tachycardic with a heart rate of 89. She is a little tachypnic and does appear a little anxious on exam with a respiratory rate of 26. She's satting, however, 96% on room air, and she's afebrile. So this is her chest x-ray. So according to radiology, this was read as normal. I pulled up the chest x-ray myself and took a look at it. And if you look at the arrows, this is not a normal chest x-ray. She's actually got a moderate-sized pneumothorax. So the first lesson from this case is if you order a film, chest x-ray, CAT scan, whatever, always look at the film yourself because you are seeing the patient, the radiologist isn't. This is not a knock on the radiologists. They systematically go through these things, but they're not really focused because they don't have the patient in front of them. I can't tell you the number of times I've found things that have been missed or that I've learned something just by simply calling the radiologist. So if you order a film, go look at it. So what would your management for this patient be? So most people probably are saying, well, patient needs a chest tube. We actually didn't put a chest tube in this patient. We put her on flush rate oxygen via non-rebreather, and we opted not to do a chest tube. And our reasoning for that was based off this trial called the PSP trial, published in the New England Journal of Medicine in January 2020. I have the PMID PubMed number for you up above if you actually want to go find it in PubMed. So this was a non-inferiority randomized clinical trial of 316 patients that had their first episode of a unilateral spontaneous pneumothorax of at least 32% or greater in size. So pretty decent sized pneumothoraces. And the comparison was chest tube, which is standard care, versus no chest tube, which they called conservative care. Their primary outcome was lung re-expansion at 8 weeks, and there was no difference between groups. So in other words, whether you got a chest tube or you didn't, the same number of people re-expanded their lung by 8 weeks. But here's the kicker. A bunch of secondary outcomes. There was less pneumothorax recurrence. There was less subsequent interventions. There was less adverse events, less inpatient days, and less hospital revisits in the group that was managed conservatively. So no chest tube. And that's lesson number 2 from this case. In select patients with a large primary spontaneous pneumothorax, a conservative management approach of observation may obviate the need for a chest tube. So what we did with our patient is we admitted her to the hospital for observation. She was watched on flush rate oxygen on a non-rebreather, and her chest x-ray the next day, her pneumothorax had improved without having a chest tube, and she ultimately went home without having any procedures done. So there you have it. Another case of chest pain that is not acute coronary syndrome and is not a pulmonary embolism. As I come across these cases, I will continue to share them and hopefully give you a couple of pearls for each case. Let me know your thoughts and comments. Thanks for tuning in, and until next time.